Hi, everyone. So once again, I'm here to take you to our last session of the day, which I am particularly interested in. We're going to be discussing novel measures and data for mental health. I will now call on our next speaker, Victoria Baranov.
Thank you so much for inviting me, and let me share my screen.
We can see it.
Great. Fantastic. Okay, so this is a great session. Actually, I think the papers are so closely related. So this paper that I'm going to be presenting is about maternal depression and child development. And here it is going to be a lot about measurement in terms of how do we measure impact of a psychotherapy RCT on both mothers and children. Typically, these are assessed using sort of psychometrics like the CSD, for example. But what we're going to be looking at is using stress biomarkers from hair in a psychotherapy RCT in Pakistan. So, sorry, okay. So as Helen mentioned, there's a very high prevalence of maternal depression or postpartum perinatal actually depression. It's largely untreated. We know that depressed mothers struggle with parenting, and there are, as Helen mentioned, also strong, well-documented correlations between maternal depression and later life outcomes for children. However, from the RCT evidence in terms of randomized evaluations which treat depression, trying to identify causal impacts on child development. Some of the studies that we do have, some of the best studies, don't seem to find very strong effects on child development up to age 8. And this could be for a number of reasons, but it is likely to be the case that it's quite difficult to measure socio-emotional development in young children at a critical age. So for example, you provide maternal depression treatment in the first year postpartum, and then you want to measure the child's socio-emotional development at 1 year of age, and that's a really difficult thing to do. So you can't really ask them questions when they're only 1 year old. And so what we wanted to do in this study is to try to understand whether we could use biomarkers of chronic stress to see if the intervention sort of gets under the skin, so to speak. And we'll be looking both at the mothers and also at the infants. So what do we pick up with these biomarkers of stress in the hair? So we pick up markers of the HPA axis. So the hypothalamic pituitary adrenal axis coordinates the central stress response system. You'll probably be familiar with cortisol, where increased psychological stress raises your cortisol levels, and that sort of prompts your body to react to, some sort of threats. And so cortisol is good in the short run in that it, sort of prepares your body for some, action and defense. However, in the long term, high levels of cortisol are sort of detrimental. They're expensive for the body to continually maintain, has sort of negative effects. Meanwhile, another HPA axis hormone, DHEA, actually has an anti-glucocorticoid effect. So what that means is that, when cortisol levels spike because of, some threat or some, some stressor, higher levels of DHEA in the brain in particular protect the brain cells from death, which cortisol prompts. And so the HPA axis is thought to be dysfunctional when depression is involved. And it also plays a key role in brain development. So at first it's, involved potentially in depression, but also it's important for, the maternal depression part, but also because we're looking at the subsequent impacts on child development. HPA axis also plays a role in brain development, where DHEA is a neurotrophic factor, which means that it promotes the growth of brain cells, of neurons. So the hypothesized mechanism of how, perhaps one of the key hypothesized mechanisms that involves the HPA axis of the intergenerational transmission of mental health is that maternal depression can impact the child development through potentially, so directly through the mother's hormone levels because she's breastfeeding. So, maternal depression affects mother's stress, and this raises cortisol levels, potentially reduces DHEA levels, and this subsequently affects the infant's HPA axis just through, or exposure to these hormones just through breast milk, but also can impact the infant through caregiving behaviors. Also, as Helen had mentioned, that maternal depression affects caregiving behaviors, which subsequently also affects infant stress. So it's a key physiological pathway for how maternal depression impacts negatively on children. However, very little is known about the physiological effects of treating depression in general, and not on the next generation. So not directly on the mothers or individuals, but also on the next generation. So what we're going to do is we're going to leverage an RCT that has been is very similar to a previous study of ours. It's a depression intervention called the Thinking Healthy program, peer delivered. So it's a CBT based, delivered by trained peers as opposed to community health workers, the original intervention that we had evaluated prior had community health workers, and this is the key difference, is that it's peer delivered for the most part, and it focuses more on behavioral activation than cognitive restructuring. And so we have this intervention that's conducted basically beginning the third trimester of pregnancy when mothers are diagnosed with depression, and it continues through this. So the main CBT-based intervention continues through 6 months postpartum, and then we continue the monthly booster sessions actually until 36 months postpartum. But for the purposes of the study today, I'm only going to focus on the 12 months endpoint. So at this 1 year, at 12 months postpartum, we collect biomarkers of HPA axis function from hair samples from both the mothers and the children. And so so we have this cluster randomized design, 40 clusters. The intervention actually involved over 500 participants who were screened as depressed, but we also enrolled a sample of non-depressed women, so the women who were screened negative for depression. And for the 12-month follow-up, we only collected hair samples because it's quite expensive from a random subset of about 104, exactly 104 dyads. So we have the depressed intervention and depressed control, which is determined by randomization, and then we have this non-depressed comparison group that will provide important comparisons to sort of benchmark the differences that we might see between the depressed and non-depressed mothers and their babies. We also subsequently followed these dyads to look at the impact on early child development of the intervention, but also for us to be able to see how the hormones, HPA axis hormones at 1 year of age predict child development, say 2 years later. And I'll try to get to that today. I'm not sure that I'll have time. So this is how hair is collected. It's collected from the posterior vortex and back of the head. Not that much hair is actually needed. I think this is in fact too much that you see here. And this is obviously collected from the mother, so this long hair. And so with the mother's hair, because they're long, you basically have this retrospective, this time series going backwards, and you can analyze the hair segments at 1 centimeter increments. And because hair grows at about 1 centimeter per month, this is sort of the HPA axis hormones over the duration of the past month. And this is the hair hormones over the duration of the past month, 2 months ago, and so forth. And you can go back about 6 months to see the sort of history of HPA axis. hormones. For infants, obviously they don't have very long hair at 1 year. They luckily in our sample, all of them did have hair in this, and this is rural Pakistan. And very thick hair is common in babies, not like my 3-month-old who is quite a baldy. She would not have been a good study participant for this. She would have caused some problems, but in our case, we did have hair for everyone, and we would analyze about 1 to 3 segments of the hair, however long the hair was, all in one go. So we don't have this segmentation just because it's too short to sort of collect and segment at 1 year. So that's how we extracted the hormones. I'll show you the results on the impacts of the depression intervention, but first show you the difference between the depressed women and the control. So this is on the effects on the women. The depressed women who did not receive the intervention and compare them to the non-depressed women. So this is sort of the, just the association with depression. What do we see with cortisol? Women who are depressed have higher levels of cortisol, so they experience higher levels of chronic stress, which is what we would expect. Cortisone is another hormone that's closely related to cortisol, so it sort of behaves quite similarly. And by contrast, DHEA, which is a marker of actually resilience, what we see is that depressed mothers had lower levels of DHEA than their non-depressed or the healthy comparison group. So what happens with this intervention? Well, the intervention basically bridges the gap a little bit between the depressed controls and the non-healthy comparison group. So we see that it reduced cortisol levels and cortisone levels. So it appears to reduce chronic stress, and it increased resilience, increased DHEA levels. I can show you, and I won't be showing you the regression tables here. These are sort of just the results that you can see. This is the actual data, like each data point plotted out. Because we have a small sample, we can do that, and you just see this strong relationship between the baseline depression severity as measured by the PHQ-9. And so these are the healthy comparison group women. So these are the women who basically have too few symptoms to be screened positive for prenatal depression. So they did not receive the intervention, but then anybody above the score of 9 would be classified as depressed. And the circles, the green circles, are the women who were randomized into the intervention. And so generally, we see this increasing slope where the greater the symptom severity, the higher the cortisol level and the cortisone levels. So greater chronic stress with higher levels of perinatal depression, but then the intervention reduces these levels of stress among the women who are depressed. And the opposite is happening, so the exact opposite pattern with DHEA. As I mentioned, we can do a segment by segment analysis. So this is plotting the time series of these hormones going backwards in time from 1 month ago. So basically at the 12-month follow-up, going backwards in time. Even though we just collected it at the 12-month follow-up, we can go backwards in time. The one caveat is with the polar hormones, which are cortisol and cortisone, you do see degradation over time. That's just as a result of degradation because of exposure to moisture. Whereas DHEA, which is not polar, you don't see this degradation over time. But these are just sort of the segment by segment analyses that we can do, in principle, you might have an intervention where you sort of did it in this month here, and then you would have a, nice pre-measure as well as a post-measure if you were sort of doing something fast. Okay, for the impacts on the infants, what we see, and I'll skip this regression table and I'll focus on just the visual results with these, with basically the raw data here. With the infants at 1 year, what we see is there's no effect of the intervention basically on cortisol and cortisone. So this might be due to the fact that infants in general have very high levels of these hormones. but we see very clear levels, a clear increase in DHEA levels. So again, increase in this resilience hormone for children whose mothers were treated for perinatal depression. And we also see, again, this clear negative relationship between mother's symptom severity and DHEA levels. So infants who and so basically what we're seeing is that the intervention helps sort of alleviate this gap or this effect of depression, which is what we would expect. Whereas in cortisol and cortisone, we actually don't really see it. We don't see a statistically significant relationship between depression of the mother and the child's level of cortisol and cortisone. So it's perhaps unsurprising that that's not where we see any intervention effects either. And so in the last sort of bit of results that we have, just very quickly looking at potentially, what are these hormones actually measuring in the child, and just using the child DHEA, cortisol and cortisone levels at 1 year and seeing if they predict the Bayley receptivity. So it's a language receptivity score, and this is an objective measure measured by our assessors at 3 years of age. So 2 years after DHEA and cortisol were measured, what we see is that DHEA is positively associated with infants or with children's language development. And so that's really sort of good to see that it is predictive, and also we don't see any effects or any predictive effects of or associations between child cortisol or cortisone and Bayley receptivity. So it's reassuring that this is where we see the treatment effect and not on the cortisol and cortisone. Okay, so just to conclude briefly, what we see is that depressed mothers and their infants differ in their HPA axis hormones. So they differ in terms of the in compared to the healthy comparison group, and the intervention impacts HPA axis activity of both mothers and infants, bringing the treated dyads closer to the healthy comparison in terms of all of the markers where we see them. And we also see that infant DHEA is a promising marker of language development in infants. So obviously in next steps specifically for us, we were hoping to collect more biomarkers greater than n equal to 100, because we're doing a follow-up through 8 years of age with this the full sample for the trial. And I don't know if that's going to happen actually, unfortunately, because of the UK budget cuts, we got a little bit slammed. So we'll see whether or not we're going to be able to get a full more of these biomarkers or not, but hopefully. Anyway, so that's all. Thank you very much.
Thank you very much, Victoria, for a very interesting and important piece of research. Abu, you are next.
Yep. Let me share my screen.
Yeah, we see your screen.
Yeah, okay. Thank you for organizing this really cool conference and inviting me to speak here. Today I'm going to present a joint work with Asad, Tabassum, and two Tanvirs. And it's a study on the vulnerable Rohingya refugees who have been forcibly displaced from Myanmar recently, their mental health, and early childhood development. And it's a work in progress. So if you have any comments, then you can ask me here or email me, or if you want, you can DM me on Twitter. So here is my Twitter handle. So to those who don't know what forced displacement means, it means that someone is forced to move from their home region or country due to conflicts, violence, or even poverty. And these forcibly displaced people have doubled in the last 20 years. In fact, now there are roughly 80 million forcibly displaced people worldwide. And among the many consequences of forced displacement, one is that it's a major driver of mental disorders like depression, psychological trauma, and distress among refugees. And these mental health problems arise due to pre-migration experiences, as well as migration and post-migration experiences. Like, for example, pre-migration experiences would be conflicts and violence they experience, whereas post-migration experiences would be like separation, uncertainty, and financial strains, and so on. So among the most vulnerable are the children and women refugees. Why? Because early life crises among children can lead to poor mental health in adulthood. Plus, there can also be poor human capital accumulation. And for women, women quickly develop complex trauma from terror, and they are also prone to sexual and intimate partner violence in refugee camps. And the depression burden is also twice as high for women than men. And women, those who are mothers, their poor mental health can lead to poor parenting. And poor parenting can also lead to poor socio-emotional, physical, and cognitive development of their children. So in short, forced displacement can have negative impact on mental health and also has many negative economic consequences. So what we do in this paper is in partnership with BRAC Bangladesh, we provide psychoeducation to Rohingya mothers living in refugee camps in Bangladesh. And psychoeducation is a combination of psychotherapeutic and educational intervention that helps people cope with mental illnesses by providing basically education and information. So why should psychoeducation improve mental health? It's because those who have a thorough understanding of the challenges they are facing and their knowledge of personal coping ability and their areas of strength are often better able to address their difficulties. They also feel more in control of their conditions, and they also have a greater internal capacity to work toward emotional well-being. So, and psychoeducation is also widely used in psychology. So what we do is we investigate whether providing psychoeducation to the Rohingya refugee mothers can improve psychological well-being of mothers and children, and whether it can also improve children's socio-emotional, physical, and cognitive development. And in our study, psychoeducation means, or it involves educating people about psychological well-being in a small group format. And it also involves parenting counseling. And there were also culturally appropriate play activities. So participating mothers and children, they could play with each other, and mothers also played games with other mothers in groups and so on. So why do we study Rohingya people? I think most of you know that Rohingya people of Myanmar are severely persecuted minorities. And after the 2017 genocide in Myanmar, there has been a mass displacement, and roughly 1 million Rohingya people now resides in refugee camps in Bangladesh. And this also makes them the world's largest stateless population. And survey reports show that women experienced sexual violence in Myanmar during the conflict, as well as abuse and intimate partner violence in refugee camps. And also, roughly 80,000 Rohingya children are estimated to have severe mental distress. Plus, they are also estimated to have malnutrition, anemia, stunting, and so on. So what we do is, in partnership with BRAC, we conducted a clustered randomized control trial in large Rohingya refugee camps in Cox's Bazar, Bangladesh, which is next to the Myanmar border, where all these refugees live now. And each of these camps has many blocks. So these blocks are like clusters of many households. I'll show you. So these are all blocks. So you can see there are many households within each block. So for example, our unit of randomization was at the block level. So for example, this can be a treatment block, this can be a control block, this can be a treatment block, and so on. So this way, we randomly selected 252 blocks where 137 received the psychoeducation treatment, whereas the remaining did not receive any treatment. So the remaining was our control blocks. And within each block, we randomly invited 14 or we randomly had 14 mother-child pairs from each block. So, and the inclusion criteria for signing up was mothers with at least one child between the age of 6 weeks and 2 years of age could sign up for our intervention. And in total, we had roughly 3,500 mother-child pairs for our study. So this is the timeline. We had a baseline survey in September 2019. And the baseline survey actually ended in September 2019. And then in October, our face-to-face sessions started. So these are group sessions. And we had 24 weekly group sessions for 24 weeks. And the face-to-face sessions, it had to end right before the COVID lockdown. And in between March and May, there were no sessions because of the lockdown. But during this time, BRAC collected mobile phone information from these households, and so that we can start the intervention again in May. So from May, we started giving the psychoeducation treatment through mobile phone. And we had 20 weekly sessions, which ended in September. And in October, we had our endline survey. So what do we find? I'm not going to go into more details. If you have more questions about the sessions or anything, I can answer later on. So I'll go straight to results. And these are our results. So these are treatment effects on mothers. So here the treatment effects are presented in standard deviations of the control group. So here the control group has mean 0 and standard deviation 1. And these effects, so the mental health, if they are on the left side, so negative means there is an improvement in mental health, whereas positive effects for other outcomes means there is improvement in those outcomes. So here we present the treatment effect with 99 and 95% confidence intervals. And what we find is, so if you focus only on the black lines, which is the pooled result, what we find is that our intervention improved mothers' psychological trauma as well as their depression. And when we look at their well-being, we find that in terms of their happiness and their belongingness, we see significant improvements. However, in terms of their future aspirations, we don't see any improvement. So here, this is surprising because we find that this is negative, but this is not significantly different from 0, basically. So in terms of treatment effect on children outcomes, what we find is that children's trauma and depression also improved. However, you can see that for trauma is significant at 10% level, where depression is significant at 5% level. So the result is not as strong as we see for mothers, right? In terms of their development, what we find is that their communication skills, gross motor skills, and their problem-solving skills, there is a strong, significant effect. A positive effect. And in terms of their social skills, we also find significant effect, but it misses significance at 5% by a small bit, right? So it's a weak result here. But in terms of fine motor skills, we don't observe any effect, significant effect of the intervention. So we also do many other analysis, which we can discuss later on, but I'll go to conclusion now, which is that psychoeducation is effective in improving mental health of these persecuted refugee mothers and their children. And improving mental health of mothers leads to improvement in children's socio-emotional, physical, and cognitive development. And I don't present some results like I said, but I think you should know that the intervention also caused the mental health of mothers to be more aligned with the mental health of their sons, but not so with their daughters. So there we observe an intergenerational transmission of mental health from mothers to their children, but only for sons, not daughters. And the treatment effect is also stronger among mothers that were highly exposed to violent conflict in Myanmar. Yes, so that's all I have. If you have any questions, I'll answer later on during the Q&A session. So thank you very much.
Thank you, Abu, and thank you to all speakers for very compelling, important, and timely presentations. I think these are all subjects that are on our minds at this time. I do have a few questions for you. I will also encourage any participants, all participants, to submit questions through the Q&A. And in case the presenters also have questions to one another, I will ask the first question, and then I will let the speakers ask questions if they have before I go on with my next ones. So my first question is to Abu. So you mentioned that after COVID, the session started taking place over the phone. What are the constraints of delivering the sessions over the phone in such a fragile context? Do you have more attrition than was it possible to reach all the participants of the study?
Like you can guess that we couldn't reach all the participants. So it was very difficult, and many of the households didn't have any mobile phones. So the BRAC authorities had to give mobile phones to these households so that we can continue our intervention. But we could collect roughly, so from the, if I compare to the baseline households, we could reach to 90% of the households with mobile phones. And yes, so it was difficult because face-to-face sessions can be more interactive. It's also more fun because they could play, they could discuss, right? So there were lots of play activities they could do with other mothers. And in these refugee camps, if you have seen any videos or anything, these people have nothing to do all day, so they cannot go outside of the camp to work or anything. So they just sit there and do nothing all day, basically. After, for example, for the mothers, it's they're taking care of the kids, but after the household chores and everything, they are not engaged in any other activities. So going to these kind of sessions where like fun activities for them, but during lockdown, it was quite difficult for them as well. So it was also difficult for us to deliver the sessions because as you can imagine, over the phone, talking to them for like 20-30 minutes, right? It was quite difficult. But unfortunately, we couldn't do any midline survey to check how much, what is the effect of these face-to-face sessions, and then we could also compare that to the effect from these telephone sessions, right? But we couldn't do the midline, so unfortunately.
That would also have been interesting to see.
Yes, yeah, definitely.
Okay, so do any of the speakers have any questions? If not, I will go on and keep my own questions.
I actually have a question also for Abu, because you didn't go into the intervention at all. Is it possible for you to just summarize what the content of the intervention was in a few sentences?
Yes, so all these 44 sessions had 44 different focus. So for example, in one session, it would be about sharing with others. So how they can share their problems with their neighbors or with their family members if they're around, and so on. And also it was so in terms of parenting counseling, it was a focus on a specific issue of child rearing, for example. So, for example, there's a difficulty in feeding the child, and then these people give advice that if you face this kind of difficulties, you can overcome by doing this and this and that.
Was
And
the intervention, sorry, was the intervention developed by your team, or was it something that was already?
It was developed by BRAC and other psychologists. Yeah, so it was not. We are evaluating the impact of it, but it's developed by external members who are expert psychologists. Yeah.
Cool.
Louisa, you are on mute.
It had to happen, right? So we have a question from the audience from Wilfried Getz, who is asking if there is a way to see how psychoeducational intervention is cost effective or not, and whether you're planning to perform a cost effectiveness analysis.
Yes, we are planning to do that because we provided all these sessions through para-counselors. So these para-counselors come from their own community. So those counselors are also Rohingya women. So it was very cheap to administer these sessions. But we haven't done any cost effective analysis yet. We plan to do that very soon. When we have the paper, I think there'll be something on that.
Okay, I will ask one more question. We're about to hit the time, but as moderator, I have this power. So my question is to Helen. As someone who has interest but very little knowledge about mental health, one of the things that I hear is that it's more difficult to diagnose mental health issues on people who are on more disadvantaged situations because you expect them to be depressed, not necessarily clinically depressed, but you expect them to be more sad, let's say. How does that affect your results taken into account? I guess that well, everyone suffered from the pandemic, and it would be expected for someone who has been more hardly hit economically to also be more negatively affected in those terms. So do these questions allow you to set apart what would be like a diagnostic of depression, or and how does that affect policy implications in terms of how to mitigate those issues?
That's a great question. So we just looked at relative differences within the population. We weren't comparing to any standard. And actually the CESD score does have a cutoff that's used in the US, which is 16. Above 16 is considered to be an indication of clinical depression, but that hasn't been validated in Bangladesh. It has in a few other low-income countries, but and there are different levels found depending on the country, sometimes mostly higher. So it's not just that they may experience a different level of symptoms at baseline, but also that the symptoms they experience that are normal may be perceived differently to us than to them. So I guess I just say we don't know who in this sample would have been considered clinically depressed because it hasn't been validated yet. But we do think that higher scores would be an indication of more depressive symptoms. So yeah, unsatisfying answer.
Okay, no, that's great, thank you. And finally, Abu has a question for Victoria, and then
Yes.
we're going to wrap up.
Yeah, it's a quick question. I really liked Victoria's AER paper, and I'm just wondering, are you looking at the effect of that intervention that took place a long time ago, or is it a new RCT?
It's a new RCT, so a completely new set of mothers and a slightly different delivery of the RCT through peers instead of community health workers. Yeah, thanks. It's a good question. Yeah, new set of mothers.
Okay. I have one more question here, and Sam, please tell me if I should just not ask it. Otherwise, I'm gonna start asking it.
Go for it. Go for it. No. Go ahead.
Okay. Thank you. I just like this subject too much. I want to keep going. What do we know about the mental health of male partners of women with depression? And I guess that's yeah. Abu or Victoria.
I can take a shot. So that's a really good question and typically quite understudied. I think we know more in developed countries, and postpartum or postnatal depression is also common, not as common among fathers, new fathers as well. But it's not, I'm not aware of that much research that is looking at the impacts of the specifically maternal depression on fathers. And we tried in our setting, but in Pakistan, for example, to look at the impacts a little bit, and we do see effects on the way that the mother reports the relationship quality with her husband. And so, of course, if the relationship quality is better, then the husband might be less prone to depression as well. Whereas if the mother's depressed and the relationship quality is very poor, then the husband might actually end up getting some negative mental health consequences of the maternal depression. But I would say we haven't measured it in the husbands, which is a real limitation. And I'm not aware of many studies that have looked at that, although perhaps Abu, you guys maybe did.
No, we were actually planning to do it for one of the projects during COVID we were doing, but it's very difficult to reach out to the husbands because they don't want to answer to long surveys and everything. So if you approach the mother, they are much nicer, but when it comes to husbands, they don't often have time to talk to people actually. So but it's a very, very important thing, important question, and like Victoria said, it's understudied. I also don't know much study that looks at these spillovers on spouses, but it's interesting. Maybe we can study it later.
I can add that there is emerging evidence which would make sense that the mental health of the father or other caregivers also really matters for child outcomes. So definitely it's needed. Interventions and more study of it is needed. Yeah.
Great, thank you. So we already know some next steps for anyone who wants to do research on this space. With that, I'm gonna thank you all the speakers for joining us, and thank you to the audience for sticking with us until the very last minute.